Hello, my name is Jessica Blank, and I'll be presenting this case entitled Keeping the Diagnostic Door Ajar. Our patient is a 43-year-old woman with untreated Crohn's disease that presented with weight loss and 1 week of fever, abdominal pain, and diarrhea. Her labs were significant for leukocytosis and elevated CRP, and imaging revealed active colitis and multiple splenic and hepatic abscesses, as you can see in the center images. Blood cultures, splenic abscess aspirate, and serologies were negative for bacterial and fungal organisms. She received multiple weeks of broad-spectrum IV antibiotics, but her symptoms persisted and her abscesses grew. She also developed pleuritic chest pain and was found to have right lung consolidations, as you can see in Figure 2 on the bottom left. Initially, the working diagnosis was a disseminated infection, but this was not supported by the worsening abscesses and continued symptoms despite multiple weeks of IV antibiotics. So a new working diagnosis was formed, and it was thought to be more of a non-infectious etiology. She was ultimately diagnosed with a rare sequela of IBD, aseptic abscess syndrome. Antimicrobials were discontinued, and she was treated with high-dose IV steroids, leading to rapid improvement. In the outpatient setting, she was transitioned to infliximab and azathioprine, with improvement of her CRP, as well as complete resolution of the deep abscesses, as you can see in Figure 3 in the bottom right. Aseptic abscess syndrome is rare, with only 61 cases reported, with one of those being in the US, and is generally a sequela of systemic inflammatory conditions, such as IBD. It normally presents as abdominal pain, fever, and weight loss, with deep sterile abscesses, often in the spleen and liver, but those abscesses can also be found in the lungs, lymph nodes, kidneys, pancreas, testes, and brain. And the key here is that there's no clinical improvement with antibiotics. This is a diagnosis of exclusion. It's often initially diagnosed as infectious and treated with prolonged antibiotic courses, and sometimes patients end up going in for surgery for procedures such as splenectomies. This leads to increased morbidity and mortality for the patients, as well as increased healthcare costs. The pathophysiology is not completely understood, but on histopathology, we see neutrophilic infiltration surrounded by granulomatous reaction. The treatment includes corticosteroids initially for 2 to 4 weeks, and then DMARDs and biologics as maintenance. The important thing here is that infection needs to be ruled out before these medications are started. So it's an important step when diagnosing and treating aseptic abscess syndrome. This case highlights the importance of keeping the diagnostic door ajar, particularly when features of the case do not seem cohesive or when the clinical course does not go as expected. Thank you for your time.